Are we live? Okay. People are starting. I think we have a number of people who are still logging in, but in the interest of time, I think we should launch into the webinar today. Thanks to all of you who are joining us for our series on COVID, vaccine confidence in a time of COVID. This particular webinar this week, we're going to be talking about the influenza vaccine in this context. I am thrilled to have a great series of panelists today, starting with Janet Tobias, who's the director of Unseen Enemy, and we'll show you a couple clips to capture kind of the field and what's going on in the world around influenza. And then a first panel on a second panel, as it were, challenges with confidence in influenza vaccine, and a co-director of the Vaccine Confidence Project, Pauline Patterson, will chair that, and thrilled she'll introduce the panel there. And thrilled to have Sandra Quinn, Dermot Gorman, and Narendra Arora from different corners of the world. And then I'll come back to be chairing our Confidence, Rumors, and Misinformation panel with Joe Wu from Hong Kong University and Simon Piatek, who leads our digital analytics. So just to launch right in, I'm going to show you two clips from Unseen Enemy, which was an incredibly powerful film that Janet Tobias made. It was widely broadcast around the world. But I think I've picked from two corners of the world in Unseen Enemy just to bring us into the context of global influenza. Let's see.
Emptied, of course, eviscerated.
I'm just trying to share my screen here. Let's see. Can you see? Yeah, thank you.
Your chicken or your duck alive. So you buy your chicken or your duck alive, and then it is killed.
Now I'm going to take you to another corner of the world. Let's see.
Shannon passed away in December, 6 months before she graduated. I never thought of the flu as being deadly. You get sick, you get well, and you go on. But now I know, since Shannon was perfectly healthy, it's not just the elderly and the very young. It can kill anybody.
The biggest pain in the world as a parent is losing their child. This is the most unnatural thing to happen to a human being. And you stand next to it and you think, my goodness, I am there to prevent this from happening, and sometimes I cannot. And sometimes I don't know why I cannot. The question of how and why one particular person may die from influenza is the million-dollar question that we absolutely need to tackle.
So I think that's set the stage for us in a compelling way, and I thank Janet. I know this was a film that these are just.
The World Health Organization has declared a swine flu pandemic.
The Zika virus continues to infect people.
Sorry.
The new respiratory.
Sorry there. I'm going to make sure we don't see a few films at the same time here. Thanks. I know this film you started in the north equatorial part of Congo because I was there as part of that, and you were going to make a film on Ebola and looking at ground zero where Ebola was first discovered, and that was going to be the primary story. And while you were making that film, Ebola in West Africa was an outbreak, and you spent months there in Guinea and Liberia, and while you were back in the editing room, Zika outbreak, and now here we are with COVID. And in the middle of that, you know, the context that we're more familiar with in a way is influenza epidemics. What are some of your reflections? Here we are in a webinar on influenza in a time of COVID, and from all the work you've done, what were some of the emotions, the issues, the challenges, and also from the influenza one, because COVID also started in Asia, as far as we know, and look what it's become. Just, I'd love some reflections from you.
Well, we went and found Shannon's story because I was actually in Liberia in December of 2014, and we thought that people all over the world were dying of influenza, but at the same time, we were all focused on Ebola in West Africa. So we looked for a case that was happening at the same time, and we found Shannon. And Shannon died on the floor of her home when her mother was giving her mouth-to-mouth resuscitation, trying to keep her alive, which is about as, I think, as bad as it gets for a parent. And she was a perfectly healthy 17-year-old that we still don't understand why she was one of those people who must have had a genetic predilection to, to be vulnerable to an immune response, her own immune response to influenza. And out of that personal story, I learned a couple of things. Is Shannon's mother and father, salt of the earth people from a small town in Minnesota, really didn't have access to the information they needed about flu shots and about influenza and what could happen. They were confused about what they found on the internet. They didn't know who to trust. Even after Shannon's death, I would go through the internet with her mother, who was like, who do you trust? Who do you trust on HPV vaccines? Who do you trust on influenza? Which was heartbreaking, right? And so out of that, you learn the incredible importance of messaging. In a crisis like COVID, it's too late to build trust, as Heidi Larson says, that you have to do it, you know, over time, and you have to do it consistently. Learned from sort of a master of communication, Dr. Tony Fauci, that you have to be really clear about your message. You have to use economy of expression, right? So that people in a short time can digest what you are saying. You also have to know your audience. This is a more academic audience, but know your audience. And it is not about being the smartest person in the room. If 3 people think you're the smartest person in the room and the other 97 don't understand what you're saying, you've completely failed. Adjusting to the culture and the conditions is paramount. And that people are hungry for people to trust and the right information. And we have to figure out how to do that. I was gonna wear Shannon's necklace today. Her parents gave me a sort of bead necklace that she put together. And I couldn't for a variety of reasons, but I think about her all the time. I don't know her. And I think how I could be connected to Shannon on the subway if I had influenza or if I have COVID, and I could give it to her. And I had a staff of people working on this project who were in some ways slightly vaccine hesitant. New Yorkers, young people. And so, but by watching and working on this project, they all on their own decided to go get influenza shots. I didn't tell them to do it, but sort of absorbing what could happen and how you could be connected to someone like Shannon motivated some 25 and 30-year-olds who were not completely sure and not sure that that vaccine was for them. And on the broader level of Cambodia is what we do to the environment, how we're connected to the environment is we are all connected to someone halfway across the world. We're all connected to what happens environmentally, as both COVID and influenza show. And we all have the power to make a difference in what we choose to do. And I want to choose to be kind to the person I don't know who I cross in the grocery store or on the subway, because what I do can make a difference to their life. And it's really true right now with COVID. I'm a rare moment without my mask. I'm never without my mask.
Thanks so much, Janet. I wish we had more time to talk to you. And it's such a, I mean, I think you summed it up well. And I think as some of us being academics, but always trying to, speak to publics, I think your points about economy of expression and knowing your audience and not being the smartest in the room. I sat next to the U.S. Surgeon General in a panel a couple weeks ago, and he quoted, I think it was from Roosevelt, but he said, people don't care what you know until they know that you care. Mm-hmm. And I think that really has stuck with me. But thanks so much for all your work. If anyone has the opportunity who hasn't seen Unseen Enemy, it's really an important film. And I think what you have in the pipeline will also be really compelling. Thanks so much, Janet. Really appreciate it, and good to get a human start to our series today.
Thanks for having me.
And I'll turn over now to Pauline to introduce our next panel. Thanks so much.
Great, thank you. Thank you, Emily, for sharing the screen. So as Emily's doing that, yes. So I will be chairing the session on challenges with confidence in influenza vaccination. And each of the speakers will have about 5 to 7 minutes. They'll have the floor to discuss their topic, and then we're going to have a Q&A session. So you'll have the opportunity to ask questions at the end of the presentation. So that's great. So, and the way that you can ask questions is if you move your mouse, there'll be a little Q&A box. So you type there and then you can type your questions there. So feel free to do that as questions pop up, or also during our Q&A session as well. So firstly, we're going to have Professor Quinn, who will be speaking on reaching minority communities with influenza vaccination. And then Dr. Gorman will be exploring vaccine confidence among the diaspora, the Polish communities in Scotland, and influenza vaccination. And then Professor Aurora will be sharing insights from India and exploring challenges with H1N1 vaccination confidence. So Professor Quinn, if you'd like to share your slides, thank you so much. It's over to you.
Good morning or good afternoon. I know we're all over the world, so let me share my screen. So thank you, Dr. Larson, for including me. I want to share with you some of the results of research, NIH-funded research, looking at vaccine disparities. In the US, African American and Latinx communities are all consistently have lower uptake of flu vaccine, and that's over years. The US in general doesn't do well with flu vaccine uptake, but with those groups, it's not only consistently lower, but given health disparities and the disproportionate impact of chronic diseases that put people at risk of severe disease, it's particularly important. I began some of my work with, before I start with this was a mixed method study. It was with whites and African Americans. So I will talk in a little bit about Latinx communities as well. But this was with whites and African Americans with extensive qualitative work, followed by a development and testing of an instrument and a nationally representative survey of whites and African Americans. We had over 800 whites and over 800 African Americans. And I'm going to give you kind of a high level perspective on what we saw as it relates to trust in the vaccine and confidence in the vaccine and uptake. And so consistently from our qualitative work through the quantitative survey, we found that African Americans had a higher perceived risk of vaccine side effects. And additionally, they believe those side effects to be more serious, such as death. For example, people reported anecdotes of people dying of the flu vaccine. We all know that higher perceived disease risk means higher uptake, and that's true for African Americans as well as for others. But what we saw is that, as that scale shifted and perceived side effect risks of the vaccine increased, then what happened is vaccine uptake began to decrease. So a serious issue, we'll come back to that. Because we live in a highly racialized society, we also developed a set of measures to examine racial fairness, racial discrimination, and racial consciousness in the healthcare setting, not in the broader society. And a couple of highlights of that is we asked it so that whites and African Americans could answer from their racial perspective. And what we found is the more that African Americans believed they were treated fairly in the healthcare setting, the more likely they were that it was associated with higher trust in the flu vaccine and higher vaccine uptake. But conversely, when they reported discrimination in the healthcare setting, it was associated with higher perceived vaccine risk and lower uptake. So we don't often think of addressing some of those kinds of institutional challenges to increase trust and confidence, but they're important. We tested people's trust in the vaccine production process, starting from when the strains are identified, and all the US major players, the CDC, the FDA, down to the provider that puts the vaccine in your arm. And African Americans had lower trust in all of those institutions. So in that flu vaccine production process and in the vaccine itself. We also said, okay, well, what are some of the factors that predict trust in the vaccine and perceived risk, both vaccine risk and disease, perceived effectiveness, which is a critical part of confidence, and perceived importance of the vaccine predicted trust in the vaccine. I think Dr. Larson and others have advocated, you have to think about hesitancy and confidence, not just in a general context, but specifically. So we did measure these in the context, general vaccine hesitancy and confidence, and then specific to the flu vaccine. And not surprisingly, we really found that trust in the flu vaccine was positively associated with their confidence and with perceived convenience of getting the vaccine, but it was also negatively associated with complacency and hesitancy. And we measured, did you get the flu vaccine this year? And how frequently have you taken it in the past 5 years? And what we found, not surprisingly, is confidence in the vaccine was more, adults with high confidence were more likely to get the flu vaccine over time. And, of course, there's a lot more nuance to these findings than I'm going to share with you today. So a couple of things, and then I want to share with you what we did last evening. One of the things we don't do in our public health communication is we typically focus on disease risk. We rarely address, in a meaningful way, perceived side effect risk, and also minimizing barriers like cost and convenience. And today, of course, safety in vaccine sites. So that is a gap in what we traditionally do. Secondly, same thing with healthcare providers, that they're often focused, not surprisingly, on disease risk and less likely to entertain and engage those conversations about side effect risk. Yet doing so is one way to increase confidence and increase trust. But what I'm going to do now is also talk about the importance of engaging community influencers with empowering them with accurate and credible information about the flu vaccine and COVID. So what I'm sharing with you now is we already heard Dr. Larson, and many of us have talked about the importance of trust, the importance of relationships. So what I'm sharing with you briefly now is last night, the Center for Health Equity, and which has been in existence at the University of Maryland for more than 10 years, held what was one of a series of Facebook Live events on flu vaccine and COVID. What we did, let me tell you about the center. 10 plus years, community engaged research and service, because we think those are both vital. We have built many relationships and a high degree of credibility, which means we can engage other researchers and with our community partners. So what we did last night was this. We had two barbers. So down here, you see where I'm pointing, down here is Mike Brown. Whoops, I shouldn't do that, should I? Is Mike Brown, a barber in one of our hair barber shops, Katrina, a stylist in one of our shops. They are long-term partners of the center. Then we brought in the former mayor of Tuskegee, Alabama, it's significant, and also hosts a radio show to moderate. Dr. Thomas with the white hat is the director of the center. We brought in several of the vaccine trials investigators from the University of Maryland in Baltimore. We brought in our community engagement director from campus, a Latina woman, a Latina state legislator, a county health officer, a state health officer, my dean, of course. And we brought in Mike Osterholm, who is, a renowned epidemiologist and a strong voice on infectious disease. The reason we brought Mike here was that when Mike talks about it, he talks about it in some of that language that's understandable, but also with warmth and with humanity and with empathy. And those things are really important. Mike recorded some of his customers asking questions about the flu vaccine, would they take it, what their questions are, and about COVID vaccine. We edited those. So we were able to bring voices of customers in short video clips to this panel. And it was then a conversation. And in that conversation, we talked about myths about the flu vaccine, the importance of the vaccine. We talked about concerns about the COVID vaccine trials, safety and efficacy. And we were able to then engage in such a way that Mike, Katrina, and others who go back, we have a community activist here, and others that go back into Black and Latinx communities have more credible information with which to engage. They are community influencers. They are trusted. They are seen and encounter populations that most of us don't encounter. So we've tried to bring what we learned from research into this, and at the same time listening to and respecting the voices of these communities to address both flu vaccine and COVID vaccine uptake. So I'll stop there and say thank you for having me do this, and I will stop sharing.
Thank you so much, Professor Quinn. Dr. Gorman, if you could share your slides as well, thank you. And I think you're on mute at the moment.
Okay, that's better. Can you hear me now and see the slides? Well, good day, everybody, and thank you very much for inviting me to speak to you. My name's Dermot Gorman. I'm a public health doctor working in the NHS in Scotland. I'm not an academic as such, so I have an honorary degree with the University of Edinburgh. So I'm going to quickly run through several.
Dr. Gorman, I think you've hit the mute button again by mistake.
Sorry, I'm just going to go through several slides with you, really based on work that I've been doing in Edinburgh with the Polish community. You'll maybe appreciate that in Britain, as in elsewhere in Europe, with the European Union opening up in 2004, there was a large movement of people, and we've a large Polish community in Scotland really since that period. The work I'm talking about is started off really with work in primary schools in Edinburgh, where we found there was very, very low uptake of the nasal flu programme, and we started investigating this, and essentially over the past 3 years we've done 4 pieces of work, and we have a research team, a small research team involving colleagues at the Health Board, and Heidi's become involved down towards the bottom here, and we have a Canadian-Polish researcher, Claudia, who you've seen credited at the beginning of this. So we did 4 things. As I say, we started looking at the nasal flu uptake. It was much lower in Polish families, and interestingly, we'd assumed that the families, perhaps we weren't very good at providing written information in Polish. We assumed that that was perhaps the problem, but there was a very high active refusal rate in Polish children. Nationally, with Public Health Scotland, we looked at HPV vaccination and found that that was low in Polish girls as well. And then we've complemented these findings really with qualitative work, both focus groups of Polish parents about vaccination beliefs in general, and then most recently, again, based on the primary schools, we were able to separate groups of parents into those that had accepted or refused the nasal flu vaccination. In subsequent years, we had put in an intervention with better written information and more, actively promoting and explaining the vaccine program. So we were able to compare the 2 groups of parents, who, as I say, acceptors or refusers, to look at their attitudes to vaccination. So what should be? Sorry, yeah, here we go. I'm not going to read all this. There's a little bit of background. As I've said, there's really about 800,000 Polish people living in the UK, about 100,000 in Scotland, often working in hospitality and the health service as well. A real feature is, as I've said, they've arrived recently. There's a lot of contact with Poland. They do go backwards and forwards, and many are young families, as new migrants tend to be young families, and they often depend on the grandparents for backup and advice about health issues. In general, the public services in the UK are quite different to those in Poland and other Central and Eastern European countries, and migrants are unfamiliar with these. They're particularly concerned about how general practice works in the UK. Now, where vaccination is concerned, the delivery is different. It's done by nurses in the UK. In Poland, it's very much led by physicians. So there's quite a lot of suspicion of the UK services. The schedule is often a little bit different. And in Poland, there's a mixture of state-provided vaccines, which are free but compulsory. And there's some that are recommended but not provided free, such as HPV vaccine. flu in different countries, as we know, is considered to be of different degrees of severity. For instance, myself working as a healthcare worker in Britain, there's pretty good uptake in my colleagues. In Poland, the healthcare worker uptake is terribly low, and healthcare workers generally won't promote it to people, and it's certainly not offered to children. Looking online at reports, Poland has got very low uptake, as I say, 4% of the population in 2019. It was one country that rejected swine flu vaccine when that came around about 10 years ago. And interestingly, with COVID, they're experiencing a large demand for flu vaccination. They don't have sufficient supplies in the country. I mean, we're struggling in the UK also, but they don't, which gives some context. More context has come from, the colleagues at the London School led, the vaccine confidence in the EU report, which shows that it's going in the wrong direction in Poland. That and other research, work that we've done, tends to suggest that Polish people, certainly in Britain, feel that the Polish vaccination program is a little less modern than perhaps it would be in the UK. They've concern about safety fears, and there's a particular and deep-seated distrust, basically, of governments and pharmaceutical companies, and that's feeds an anti-vaccination movement that's pretty lively in Poland, and as I've said, that feeds into people's behaviour when they're living in the UK. So I explained that we did this work looking at families that accepted and those that declined the flu vaccine, and clearly those that accepted had much more positive views about vaccination and were more concerned about flu as well. But the things that influenced them most were their previous experience, but also, as I've said, the key thing was the fact that they're living largely in a Polish media context, even in Scotland, and relying a lot on their family members. Those that declined vaccine were more likely to cite basically scare stories on social media than those that accepted. And we know that there's quite a lot of anti-vaccination material is spread that way. And we know that the Polish community in Britain maybe rely on social media more than others might do. So that's really the sort of the feedback we were getting from the two elements of qualitative work. So as I've said earlier, just particularly to give a bit of context on flu and COVID in Poland, as much as I know, big demand for flu vaccination. As I've said, that may feed through to the UK because, for instance, where COVID was concerned, you may know that the Polish government actually sent a number of rescue flights to the UK to bring Polish people back in March because we were deemed to be doing pretty badly in the first wave of the COVID response. Poland has had 5,000 COVID deaths up until now. We're nearly 10 times that in the UK. COVID conspiracy theories are prominent in Polish and other communities, and we've seen that. We've a lot of Polish people working as care providers, and we've seen, for instance, in the COVID testing program we've had for care providers, we've found that sometimes Polish and other minority ethnic groups, often South and Central Americans actually as well, have been reluctant to take part in the swabbing program, feeling that it might give them COVID. So that was really what I wanted to say, to give you a little bit of context. We have a small body of work, mostly published in Vaccine, on this, that you're please, you're welcome to dip into that, obviously, and I'm very happy to be contacted about anything. So thank you for listening, and it's a major triumph for me to get my screen to work. That's great, and speak at the same time.
Great, thank you so much. So we've been to the US and Scotland, and now we're moving on to India. So Professor Arora, if you're able to share your screen.
Yeah, thank you very much. Okay, yeah. I hope you're able to see my slides. Can you see my slides? Emily, are you able to see my?
Yes, we can see your slides.
Yeah,
Yes.
yeah. Thank you very much. So I will talk about the H1N1 outbreak in India, which started in 2009, and the peak was in the first 2 or 3 years, and thereafter the reporting has come down, and not much information is available, but there are good lessons, as we saw both from US data as well as from European data. So between 2009 and 2010, we had almost 45,000 cases, and some of the dark the areas had maximum cases. So this is in Western India and South Indian states. And deaths were also in the same area. And I hope it is highlighted. Yeah, and in these green areas, there was practically no death, but otherwise deaths were distributed all over the country. So the most part of the country was affected. And as an emergency measure, Indian government imported, till that time, no influenza vaccine was manufactured in India. So 1.5 million doses from Sanofi was imported. And local manufacturing by Serum Institute started. And in a short span of 3 or 4 months, by October 2010, 10 million doses were released into market and for use by various constituencies. So so I'll share some of the experiences from some of the states and certain groups of people. So one of the first experience was from Karnataka. It is South India based state, where almost 150,000 doses were supplied, mostly from health workers. It was made compulsory. So almost all the doses were used, but there was considerable apprehension among the beneficiaries. And the number of, most of the people got the vaccine, they were all health workers. So because it was mandatory, they all received the vaccine in Karnataka at that time, though there was some apprehension. Now, here is the interesting part. Maharashtra is a western state, and maximum deaths occurred in this city called Pune. And Pune received 2,000 doses from the first lot of donated vaccine. It was to be for health workers. And although it was made compulsory, but only 100 health workers took the vaccine. And there was a strong misconception and rumor about GBS occurring after vaccine. And a lot of people thought that because influenza occurs every year, so they might have had acquired immunity from prior exposure. So you can see that less than, just about 5% people took the vaccine, although the number of doses were so small. And I must say that Pune had maximum mortality during that period. Despite very high mortality, the health workers won't take. And obviously when they were not taking, they were also not promoting its use. In the next round, by that time, the Indian vaccine had come. And when the Indian vaccine came, immediately the uptake increased. They had released 10 million doses. So between third and fourth quarter of 2010 and then 2011, the vaccine uptake gradually increased. but then it started declining after about 12 months of increased usage. And pandemic was declared to be over at that time and fewer cases were seen. So that complacency came, and there were also no clear-cut guidelines of who should receive or who were the priority clients. In addition, there were other issues, and which I heard from other: cost of vaccine, where the vaccine is available, whether it is available or not, and issues of low perceived risk of the disease. Just like we were informed about Polish community by Dermot, that it was perceived as a common cold. So a lot of people who refused had that low perceived risk. And the third state, which had very high occurrence, the issues, the impact of the pandemic was pretty high, as you had seen. This was one of those 3 states which had maximum cases recorded. Among the students, it was only 1/9 of the students of the student population received the vaccine. And same issues: safety issues, low perceived risk, and the students didn't want to be experimental animals. They thought that it is an experimental vaccine, and they also thought that face mask and availability around the same time, the antiviral was also available, and hand washing is effective, so they were not taking. And the risk perception overall among these students was moderate to low in 3/4 of the student population. And so the vaccine was received by a very small population. Now, this was something which was very disturbing for both the health department as well as the manufacturer. And as it is shown that the government supported development and production of this vaccine by Serum Institute. They produced 10 million doses, but they were able to sell only 3 million doses, out of which about 100,000 doses were given free of cost to various industry workers. 7 million doses were unused or unsold, and they were discarded because there were no takers, and the shelf life was lost. So overall, what the message we get from this whole experience, that there was no social mobilization or awareness created in the community. Number 2, that the health workers themselves were not convinced about the value of the vaccine, despite high mortality. In certain areas, it was up to 14% mortality. And the third component was that various sections of the population, they had this misinformation about, exaggerated misinformation about GBS particularly. So it was quite and in fact, after that, Serum Institute stopped producing this vaccine. So I will stop at that, and we'll be happy to answer if there are any questions. Thank you.
Great, thank you so much to our 3 panelists. So do please feel free to put some questions. I see there's a few questions popping up. And while that's happening, I have a question for the panelists. So reflecting on your lessons learned from your research and seeing the impact of the COVID pandemic in your country, do you think the COVID pandemic will affect your next flu season, the flu vaccination program in the next flu season? Positively, negatively, how, and what can we do about it? So I'm opening that up.
So maybe I can come up as first to answer that. It is very heartening. This year I asked, and this is informal, that the sale of flu vaccine, quadrivalent flu vaccine is available, and it is manufactured in India. It has increased by 3 times over the last year, because there has been a lot of information in the lay press that flu vaccine may help in protecting you or reducing the impact of COVID. So the vaccine uptake increased, and so although there is no systematic campaign, the uptake of voluntary uptake of the vaccine increased several times this year.
I mean, I can contribute from Scotland. The demand has gone through the roof. As an example, in the borders, when invitations went out and people had to phone in to make appointments, it resulted in the hospital switchboard crashing, and that's happened around the different parts of the country. If you look at the Scottish press, you'll see 1 or 2 health boards have had real problems with the dealing with the demand, and it's become a political issue. So it's certainly demand is sky high, and it's difficult meeting that demand, especially actually with the general in the UK and in Britain, the GP contract has changed this year, meaning that it's not being delivered in the same way as it was last year. So we've been having a hugely increased demand and different mechanism for delivery, and that's been very challenging for people, especially in the middle of COVID. And one benefit of this is we've been training new workforce, which should be available for the COVID vaccine, which is being suggested is going to be coming in dribs and dripping in before Christmas, hopefully. So yeah, it's been hugely important. I think there'll be differences in different groups. As I mentioned, migrant groups may think differently about it. They do think differently about vaccination, broadly speaking, bringing the attitudes from their home country.
And I would echo that, in many places, health officers are saying that, the supplies they got have run out. That's good news, right? Even what we saw last night in our session, one after another of people that our barber interviewed said no. So I think the question will remain when we look across the country, do we still see disparities? And I think we will see probably some improvement on where we typically are, which is African American and Latinx people down in like 30%, because they've been so hard hit by COVID. But will we, suddenly skyrocket to extraordinary levels? I think that will remain to be seen. But I do think that the COVID vaccine and how it rolls out and what our experience is with it, if it's positive, that will bode well for the future. If it's not, then I fear for what that will mean in the next flu season.
Great, thank you. We have a question from the audience. As the first batch of COVID vaccine is intended for health workers, it is critically important to get their agreement to receive the vaccination. What do you think are the key messages to get across to this particularly educated audience group who are already aware of the medical benefit?
Can I jump in first, just because I've been talking with some healthcare providers a lot recently? I think one of the assumptions we make with healthcare providers, and this may be different in the UK or India, but is that they also fully understand the vaccine clinical trials process, that they fully understand the approvals process and the implications of the quick moving process we've had. I think that's probably not true for most general practitioners. And so I think one of the messages really has to be about helping them be armed with understanding that process and the implications for safety and efficacy, and the importance of them as a role model, which is, in many minority providers are no less likely to stand up and say, I'll take the vaccine, than the general communities of color. And so I think it's really vital to get them on board.
If I can come in and respond to that. The the NITAG in the country has already started working on a communication strategy with the health providers and at various levels. And one of the important thing is involvement of the regulatory authority to give a wide and clear message across that there is no cutting corners when approvals are given, and no shortcuts as far as safety and efficacy of the vaccine. And this is particularly directed to the general public also, but mostly focused on health providers, number one. The number two, that we have also gathered statistics and which clearly shows that risk of acquiring infection in health providers is 3 to 5 times higher, and which has also led to increased mortality and hospitalization. So, so it becomes all the more important that on one side they are our warriors and they are fulfilling their task, but on the second hand, simultaneously, they need to be very much aware, be accepting. Another category of people besides the health worker we are trying to use as advocate of vaccine is the police personnel and the other emergency service providers like municipal employees, because they have also been working throughout and supporting the maintaining the services. So they are also having the challenges, and we thought that we would use them as strong advocates why it is important to be protected and receive the vaccine. I'll stop at that.
Sorry, but yeah, I mean, my experience is that you know, healthcare workers in the UK, they're aware of the risk, if you like, of a rush through vaccine, so they would be a little bit concerned about that. They're very keen to be protected from COVID themselves, and I think there would be enthusiasm for the vaccine. There's also would be enthusiasm for antibody testing and knowing more about their immune status now. So if they believe they were immune without a vaccine, they would be keen on that. That's for sure. They're also aware that even being vaccinated to start with, it might protect them individually, but it mightn't be meaning that the population is safe and the world will go back to normal again, because we won't have herd immunity for a long while. And I think that's something that's maybe not well understood by the general population. You know, if you get individuals protection is one thing, but you know, the community being safe is a different proposition and will take longer. You'll be wearing your mask for a long time, I'm afraid. Yeah, that's my perspective anyway.
Thank you so much. Unfortunately, that's all we've got time for in terms of discussion, but we will respond to your questions by typing answers as well. So thank you so much to our panelists. And Emily, if you could share the slides to move on to the next session. Thank you.
Sorry, I was speaking to mute, which is not helpful. Thanks very much to the last panelists. I found this very strong theme of trust coming through. I know with Sandra bringing these trusted members of the community together was really compelling. And what I particularly loved was the fact that it was outside of the usual suspects, as they say, and really community members outside of the typical health delivery stream, which I think we don't do enough of in the immunization field. So that was a really important cue for COVID. And Dermot, I have worked closely with on the work there. And I think what has been most compelling to me in those in that research, and what our findings was this diaspora of sentiment, that we cannot forget how connected the world is through these language networks, which are also trust networks. There is an element of trust in a common language. And Narendra, we've worked together a very long time, and the H1N1 story in India and the hesitancy on the part of the healthcare providers, I think, is a huge signal to what we have ahead with COVID in terms of healthcare professionals and needing to get them on board, because they're going to be the front line. So thank you, all of you. And it's a perfect segue to the next, to our panel now on confidence, rumors, and misinformation, but particularly the confidence part. And the reason, and what we're going to talk about here between Professor Wu and Simon Piatek here at the school, is the importance of listening, which I think from a trust building perspective, trying to listen and understand will be key. So before, and we're looking at new ways to do that using social media, which has frankly been particularly helpful in during this lockdown time. There's a lot of things we would normally do with, face-to-face focus groups that actually we have gotten different insights because of social media than we might not have had without it during these difficult times. Joe, over to you. I think we have your last slide rather than your first slide. We can't hear you, Joe. We did hear you before, so hopefully. You're not muted, so.
Joe will have to log out and then log in again. Otherwise,
yes,
there must be some, yeah.
Maybe we'll move to Simon and then come back to you, Joe. Okay, thank you.
That is absolutely fine, Heidi. Hi, everyone. I was actually hoping to have the last presentation of the day to be a conversation starter, but that's absolutely fine. Understandable technical issues. I'm going to quickly share my presentation. Just want to check if you can all see that.
Yes.
Yeah.
Yes.
Thanks, Heidi. So I think you would. I think what I'm going to talk about, you might find it, and I'm sure you will find it very, very different, especially when it comes to how we're presenting things and what we're talking about. And by that, I mean the team that's worked on this presentation. We do listen to social media. We do have tables. We we are trying to understand the reach, the engagement, and the number of likes, and how many people talk about certain issues. But at the same time, we also like to qualitatively be able to see what people are actually talking about and what they care about. So when I'm talking about mitigating the impact of rumors, of misinformation, and that is not just around COVID or influenza, flu vaccine, or this is actually about any vaccine that you can think of in any context, in any geography. So it might be actually a little bit controversial to start with, because I want to start with something that's a little bit political, but let's just completely remove that from the political perspective. The quote you're looking at the moment on the screen is something that the Polish foreign minister said in Berlin. For those of you who know the history, 1939, the history between Poland and Germany, that is something that could be considered, and was considered, very, very controversial at the time. That was right after 2008 crisis. If you look at the date 2011, that was the Euro crisis. We're looking at Greece, and he actually said that he fears the German power less than he fears the German inactivity. That is very much, again, saying that we need to completely remove the political context of that, the situation we are at the moment. The inactivity is going to cost us more than actually doing something. And that is I would actually like all of you to think of my presentation from that perspective, that it not only will cover what we're doing, but most importantly, what we possibly should be doing when it comes to the COVID and the pandemic. So where we are at the moment, if you're looking at my screen, on the right-hand side, you can see the example of the post that is very scientifically looking post, and it is sending or selling the message that there's something wrong with the vaccination, that is actually going to modify your DNA if you take that vaccine. More broadly speaking, what we're seeing at the moment is that the anti-vax movement is very actively capitalizing on the COVID-19 situation. And again, it's not just about a COVID-19 vaccine, it's about any other vaccine you can think of. And they are much more nimble, they're much more responsive when we compare the communication that we're seeing from the official accounts of governments, universities, or any other entities that could be promoting vaccination. And we conducted a study that's very, very recent that will be published, I'm hoping in the next 3-4 weeks, that was funded by the UN. And this is to do with the understanding of misinformation and the impact of misinformation on people's perception, but not just perception, but actually the willingness to get the vaccine. There's a very, very simple study design. We asked people how willing they are to get the vaccine for COVID. Then we showed them 5 examples of misinformation, and then we asked them the same question again. And the results we got were stunning in a very negative way. We found out that 6.4% people in the UK said that they were less likely to get the vaccine, and that was 2.4% in the US. Obviously, it was just, one exposure. You could say it's one-off. Obviously, how people interact, how people consume social media is very, very different. If you look at the context, it usually takes time. People do it over time. And just one-off exposure, it could not possibly tell us, actually give us the entire picture. But at the same time, it gives us this kind of indication of what could be happening when people are there on their mobile phones, when they're seeing what they're seeing there, and what they are thinking. But let's just have a look what they are actually seeing when they are browsing on their mobile phones. If you type in search on Twitter, and the example I'm showing you here is actually from Twitter, but exactly the same principles apply to Facebook, YouTube, any other social media you can imagine. there will always be the official information linking you to the official government information in your respective country. So what you're looking at here at the moment is the NHS website, and then you continue scrolling down and you're going to see all the other information that you see from the public. So let's have a look at how this official information looks like. So this is the official page that millions and millions of people in the UK are seeing when they search for coronavirus. So if you look at it from the sort of very top-down perspective, this is perfect. This comes up right at the top of the search. People are being taken to, they're being taken to the official information on the NHS website, and they can read all the information backed by science, and it's clear. They know where to click. They've got all they need. But at the same time, think of it from the perspective of the user. Think of it from the perspective of the audience. How many times, if those people are exposed to this, say over a period of 2, 3, 4, 5 months, are they going to click on that information? They're going to do it once, maybe twice, assuming that this might change. But what they're going to do after that, they're going to continue scrolling down and searching for other information. I'm not saying that whatever they're going to see there is going to be misinformation. Most likely platforms are getting very, very good at removing misinformation, or working on their algorithms so that the misinformation is somewhere down at the search results. But they will always be able to find some misinformation still. So this is, for example, what they are saying. So this is possibly one of the most extreme examples here. And in our study, we found that this type of misinformation doesn't really work. It doesn't shift people's opinion. It doesn't change the willingness to vaccinate. But at the same time, if this was more scientifically looking information, it actually does change. So these percentages that I showed you on my the third slide are percentages taken from this kind of more scientifically looking misinformation. But this is essentially what people are exposed to. And if you're in the US, that might be slightly different, but obviously platforms and algorithms make sure that you've got all the relevant content that works for you. So if you happen to live in Texas, most likely this is, if you keep on scrolling down, this is what you will see eventually. And if, for example, we don't need to talk about geography only, we can also talk about these information bubbles depending on what you're interested in. So for example, if you're more into science, this is the type of misinformation you might be exposed to. So sooner or later, if you think of the perspective of a month or two, you will definitely see some of this. So it's not just academia, it's not just big pharma, it's not just governments, pretty much everyone. We are thinking about what we can actually do about this and how we can react to it. So again, the image on the right you are seeing here, I'm not going to go into the theory of misinformation and how it's being done and how context is very, very important. Because very often both pro and anti-vaxxers are actually referring to the same sources, they're just changing the context. So again, I'm actually trying to do a little bit of that here. So what you can see here is the context of that very famous image from I think from the 30s, from Nazi Germany, of one person being against it, that is still being used in a very, very different context for different purposes. But that is essentially what is happening. We all agree that we need to get our communication right, and I actually heard during all of your presentations that there's absolutely no doubt that we need to think about that. We all agree it needs to be effective, evidence-based communication. We all agree it needs to be data-driven. That is something that is changing, because previously it was more driven by the understanding of health authorities, whereas now we are going into that new space that is becoming increasingly data-driven, and we're seeing that interest as well at our work at the VCP and London School of Hygiene and Tropical Medicine. But we need to think of new ways of approaching these audiences and new ways of engaging with these audiences. And very much from my perspective, which is very, very digital, I very, very strongly believe that this is our big moment of opportunity. We just need to be able somehow to find a way how we actually do that. And I think this is the most important slide and pretty much a takeaway from my presentation today. The three key things we need to focus on. First one is conversation. This cannot be top-down communication, governments talking to people. I showed you that example of the NHS website that is always the same, and it doesn't matter if you go and visit that website in March 2020 or July 2020, you're pretty much going to see exactly the same information. This is a perfect example of a top-down communication that we are seeing increasingly that it just doesn't work. It's not conversation, it's a one-way communication, which unfortunately doesn't work anymore. And at the same time, we need to rethink the role of the messenger. So it might be a historical context, but we all tend to think that if we're going to get Oxford University or the British government or the US government or any government agencies sharing information about coronavirus or any other illness or the vaccination we're thinking about, people are going to trust it. We are in a very, very new reality. I 100% understand that might be very, very controversial. I'm not saying it needs to be Kim Kardashian or it needs to be Bollywood star in India, but I guess as a conversation starter for to actually start that search for new and trusted messengers, we need to open up this conversation. We cannot rely on universities and official accounts anymore. We need to build a completely new network of trusted messengers, and these are not necessarily going to be, you know, the NHSs of the world. And finally, I think this point, some of you actually touched on that, the importance of content. So again, I showed you that example of the NHS website and then a few examples of misinformation that is being spread on social media. The understanding of what content works, what content shifts opinion towards pro-vax rather than anti-vax is absolutely crucial. Our study, as I said, it will be published in about 4 weeks, shows that scientifically sounding misinformation does change opinion, but scientific information, a true factual information, doesn't change people's perception, doesn't change people's opinion. It doesn't help to shift them towards actually accepting the vaccine, and that is to do with any vaccine. So again, as a kind of conversation starter here, I'd like to rephrase that quote I used right at the beginning. I actually do fear academics, governments, healthcare professionals, big pharma, you actually name it, and if they're not engaged, I actually am very, very concerned that this inactivity or this kind of way of engagement that is considered as very, very inactive by audiences is actually going to do more harm than better. Thank you very much.
Thanks, Simon. I think that's a compelling note there. And I understand why you wanted to be last with that note, but we won't forget it. Joe, how are we doing with voice?
I'm here. Can you hear me?
Oh, wonderful. Great.
Great.
So, for our last speaker, we have, and welcome back, Joe Wu, Professor Joe Wu from Hong Kong University, who's also one of our key collaborators with the Vaccine Confidence Project. I'm really happy you could join, and thank you. I realize it must be getting quite late there, but thank you. Over to you.
Great. Sorry that I'm having trouble with my slides. I've emailed my slides to Emily, and if Emily can help me show on the screen. Great. So in the next 5 to 10 minutes, I'm going to talk about some of our plans with Heidi's group to develop digital analytics in order to monitor and listen to vaccine sentiments on smartphones and on the internet. Next slide, please. Emily, can you please move to the next slide?
Yeah, sorry, just technical difficulties on my own. Sorry, it's stuck.
So as many of you know, vaccine hesitancy has become one of the major global threats, as the WHO has announced last year. On the left is the Wellcome report from 2018, showing the percentage of people who believe the vaccines are safe in different parts of the world. And there seems to be a correlation that high-income countries tend to have a high percentage of people not believing that vaccines are safe. But as Heidi's latest paper in The Lancet showed, this percentage and also similar metric varies with time. So they're not static. They change from time to time, especially driven by events, for example, when there's misinformation spreading, or if there's concerns about vaccine safety, such as the current flu vaccination in Korea at the moment. Vaccine sentiments will change. So there's a huge need in order to mitigate vaccine hesitancy. There's a huge need to monitor vaccine sentiments and also note the emergence and spread of vaccine misinformation as soon as they come into existence. So Heidi's group has been, the Vaccine Confidence Project has been monitoring the internet for such information for almost a decade already. And what we propose to do is to automate the process and also massively scale this operation by developing AI chatbots in order to do that. So the next slide, please.
Let's see, great.
So chatbots has been used in many areas, especially commercial areas such as banks, in order to serve their customers 24 hours a day with as little human intervention as possible in order to sort of standardize response. However, the use of chatbots in healthcare has been relatively slow, but fortunately has begun to become useful as AI technologies improve in clinical settings recently. And this year, because of the COVID-19 pandemic, their penetration into actual clinical settings has been speed up a little bit. And these two papers, recent papers, published in Digital Medicine and also NEJM Catalyst, sort of summarize these recent use of chatbots in our fight against COVID-19 pandemic. In particular, the UPenn group, in the School of Medicine, have been one of the pioneers in developing these chatbots. Sort of like they have a big group of AI people working with the clinicians in order to develop clinically relevant and acceptable responses to help their patients understanding COVID better, and also sort of like evaluating whether their symptoms might be COVID, and what would be the next logical steps for their patients to seek care. So our group think that these chatbots would be particularly useful in the context of understanding vaccine sentiments, because as mentioned earlier, at the moment, for example, there's a vaccine concerns in Korea, So I think they've vaccinated about 15 million people in South Korea against flu this year, and they have registered about 40 to 50 deaths, and there's a big concern on whether there's excess death due to these flu shots. And my understanding is that I think several other countries have suspended their flu vaccinations because of what they're seeing in Korea. But Korea itself, I think, is still continuing the vaccination program. I think they're investigating whether these deaths after vaccination might be actually attributed to the flu shots. So in these events, I think they're quite intuitively, public will have concerns on whether flu shots are safe, especially for example, this year when there's a lot of public health public health officials advocating flu vaccines because of the potential double epidemic between flu and COVID. So in this context, I think if we have some AI chatbots, and if there's a huge amount of public concerns about vaccine safety, then the public health agencies, the local public health agencies, will not be too overwhelmed by questions from the public regarding vaccine safety. And also the response can be better standardized in order to have only one voice instead of patients having needing to talk to different agencies which may give them different answers. Next slide, please. So our proposition is that developing vaccine information and listening to vaccine concerns using these chatbots could improve vaccine confidence in the vaccine hesitant groups and also influence their vaccine decisions. And also by detecting early emergence of misinformation and disinformation, we can help control their spread and mitigate vaccine hesitancy. There have been several recent studies, not in the context of vaccine hesitancy, but for example, in psychiatry and also in the acceptance of chatbots among people in terms of how willing they are to disclose their history, their doubts, and their questions compared to a human being. And what they find is that, although this is relatively preliminary, but what they find so far is quite encouraging. It shows that people do accept chatbots, and in some examples, they are even more willing to disclose their histories and doubts and questions to the chatbots compared to a human being. So these results, I think, support our propositions that chatbots, especially when they are designed to communicate factual information rather than to issue clinical guidance, will be particularly useful. Please. So this is just sort of summarizing what I've said so far, that with these automated AI chatbots, there's a possibility that we can do real-time, high-resolution surveillance of public concerns about vaccine safety and effectiveness around the world. It could also serve as the bots can also serve as a crowdsourcing platform for misinformation and disinformation. For example, when people who have concerns about vaccines talk to the chatbots, those would be the questions that could indicate early emergence of why people, what new concerns they have and where they are from. And also, such a platform will help us to understand how we can craft our message, our vaccine message better, so that by monitoring the response of the users of the chatbots with respect to our messages, we can sort of like iteratively improve the effectiveness of our vaccine messages. Next slide, please. So this is just a schematic of my thinking of how the chatbots will work, starting from the left-hand side of this figure. The user would start the conversation asking, for example, are HPV vaccines safe? And then the vaccine bots will use some AI technology to try to understand what the user is asking. In this case, it's a very simple question. So the response might be that to inform the user that there are currently three HPV vaccines, and those are their names, Gardasil 9, Gardasil, and Cervarix, and all three have been shown to be very safe among the millions of people who have received them. And then next, the user might ask more questions. For example, how effective are these vaccines, and actually what is HPV, and how is HPV related to cervical cancer? So the bots will have to be able to understand these questions and to issue to generate an appropriate response, and also to detect questions that the bots are not designed to handle. So for example, at the moment, I think the bots should be, as mentioned earlier, just provide factual information. So when the question is sort of beyond the scope of this, then the bot should be able to respond appropriately by saying that, this is not something that this bot is designed to answer. We would, for example, refer the user to the appropriate public health agency for the questions that the bot is not designed to answer. Next slide, please.
Joe, I'm really sorry, we're coming close to the end. So I appreciate there were some difficulties, but maybe move
Okay,
through.
so just maybe half a minute.
Yeah.
So finally, these are the implementation challenges. Primarily, laws and regulations are most important, because at the moment there's no laws and regulations regulating, when, for example, regarding data privacy, data ownership, etc. Next slide, please. So this is just to, if in the audience anybody is interested in this line of work, we are currently hiring data scientists, and we would like to receive applications from interested parties. Thank you.
Yes, that's for both the joint London School and HKU positions also. So copy both of us, because it's one big team, and it'd be great. Thank you, everyone. We've come to 3:30. If people are willing, I would hate to cut it off here, but maybe we can take just a couple questions for those. I don't know if do we have any specific to the last, let's see. There's a question from here. If I think this is more for Simon. I'll do one for Simon, one for Joe, and then try to do the responses to the others on email. Just to Simon, if scientifically looking fake info is convincing but scientific true is not, do I conclude rightly that it is about prior belief more than about science either way? And how should messages look to alter beliefs? I think that's a very good question and an interesting conclusion. Simon, do you have comment on that?
Absolutely. Thank you, Heidi. Thank you very much. Thank you very much for the question. I think very much so. The beliefs that people have are not necessarily linked to vaccine. I think this is all linked together, because when we look at the data, we are seeing that people who actually do believe in alternative medicine, we see people believe in alternative when it comes to politics. It might be different in different countries, but it is very much the case actually all over the board that it is happening. When it comes to actually addressing that, I think the problem that we're having that we like to think about it, and I think it actually goes back to what Heidi, you are advocating in your book, how we build trust. And there's no way we can build trust, and I've been saying this for months now, through this top-down communication. It needs to be conversation. And I think this is the only way we can actually build trust. And when you think of a conversation, it's not us presenting to people and asking them to consume and accept. It is the exchange of opinions. And this is only through this that we can actually succeed with this. So that's my very, very short answer. Thank you.
Thanks, Simon. And I would just add, I think we need to look at too how, not just that one is misinformation and one is, although, scientifically looking, and the other is credible, we have to look at how they're presented. I think it's partly underlying beliefs, but often the incorrect scientific information, the language around it is more emotive. There's usually other things in the communication besides just the scientific part. And that I think would influence rather than I think it's also about the dryness of some of the accurate scientific information and the way it's presented that we need to be looking at, but we do need to look more at that. Joe, actually, there was a question to you, but it was more about what exactly a chatbot is. I think you talked about that, and maybe that question came in before you did, but maybe can you say a couple things more? I think people want to understand.
Sure. So the most well-known chatbots are iPhone Siri and Google Assistant, but those are very, very general purpose. They are basically trying to mimic a human response to any questions a human would speak to Siri or Google Assistant. In our case, we are much more specific. What I envision is that these vaccine chatbots will be primarily giving out factual information rather than just maintain a conversation or try to understand a wide variety of different questions. So it's, I think, a lot more easier to design and optimize. In general, there are two big categories of chatbots. The first set is the pretty simple one. So you sort of pre-specify the responses, and then whenever the users ask a question, then you try to match his question or her questions to one of your preset message. Whereas in a more complicated version, more recent generations of chatbots use natural language processing to, for example, in the schematic that I show, the last sort of set of questions asked by the user, whether HPV vaccines are effective, what is HPV, etc. So the bots will have to sort of like decompose those sentences into different questions, be able to do that. So that will require the use of natural language processing in order to understand what the user is asking. Over.
Thanks so much, Joe. And unfortunately we'll have to come back to the others by email. I just will add to Simon's reference to my book. It's called Stuck, and stuck in the conversation, but also stuck as an injection. But anyway, it's a bit more on the politics of polarization and vaccine controversy. But thank you to everyone. I really appreciate the panelists today. I think we've gotten quite a global perspective on the different issues of influenza in a time of COVID. And I think the biggest thing that's been the power of COVID in the case of influenza vaccination is that it's increased the uptake of intent and acceptance of flu vaccines, which it looks even more, people have more confidence in that. And let's see how we go with the COVID vaccine. But thank you again. Let's hope that kind of intent and willingness transfers. But thanks to everyone, particularly the panelists and all of the participants from around the world. And look forward to hopefully seeing you on our next webinar will be on the emotional determinants of health. And we'll be following up with everybody who's registered here on date and time. Thank you very much and take care. Bye-bye.
Thank you. Good night. Bye-bye.
Stay safe.